Welcome to AETCM, the Emergency Medicine channel. A 23-year-old male patient came to ER with acute onset of breathlessness. On initial 10-second assessment, patient was conscious and oriented. On primary survey, airway was patent, patient was talking full sentence. Breathing part, SpO2 86 on room air, and started on oxygen on face mask of 5 liter O2. Then it becomes 96 on 5 liter O2. And respiratory rate is 28 per minute. On auscultation, bilateral scapular and infra-axillary crepitation is there. On circulation part, heart rate is 110 per minute and BP 110 per 70. All peripheral pulsation felt equal. CRT is less than 3 seconds. Disability E4, V5, M6 and people's bilateral equally reactive. Exposure part temperature is 100 degree and GRBS is 127. It's the primary survey, sir. Then adjoint to primary survey, we taken ABG. ABG is showing pH is 7.38 and PCO2 38. PO2 is 66 and bicarbonate is 22. Then adjoint to other survey, we take EC.
So the ABG was showing?
pH is 7.38 and
showing
features of hypoxia.
Hypoxia, no acid-base disorder, just hypoxia.
Hypoxia, sir. And then we take an ECG. ECG showing sinus tachycardia and routine bed investigation. And total count is 19,000 and CRP is 91.42. Routine investigations are recent.
So a young female, young male presents to you with acute onset of breathing difficulty with bilateral chest findings of crepitation associated with hypoxia and elevated total count and CRP. Most probably LRT. We need further history to understand what are the differential diagnoses.
Going to ample history. 23-year-old male patient with there is no any comorbidities. Patient had an allergic history of RTA on 3 days back.
When you say ample history, ample is the acronym for allergy, medication, past history and all. Then you have to say in that order. Or else say it as history. You can say history of the patient and just start off like our normal history taking. Okay. But ample history, that is that format.
There is no any allergic.
No, just say as history and continue. Don't go for ample. This is not a trauma case, right?
History-wise, 23-year-old male patient. Patient had an allergic history of RTA on 3 days back. Patient is a helmeted bike rider. Patient skid and fall, followed by his bike fell over his right leg. Then here there is no any loss of consciousness, trauma, ENT bleed. Patient taken into an outside hospital. Clinically and imaging wise, they diagnosed right side femur shaft of fracture. Then during the course in the hospital, on 3rd day, patient developed fever, cough and breathing difficulty and desaturation on room air. Patient desaturation to 80% in room air. Then the patient, then they shifted the patient to our hospital for further management, sir.
Okay.
Then history-wise, patient had on 2nd day, 3rd day of hospital admission, patient developed the fever, cough and breathing difficulty, desaturation. First diagnosis we as hospital acute.
That is diagnosis. We are now in history. Then examination, head-to-toe examination is there, right? For that, there is no point in jumping to diagnosis. So this patient had admitted for fracture shaft of femur, isolated shaft of femur fracture post RTA. 3rd day, patient started having new onset fever, breathing difficulty and desaturation. What other history do you want to ask? Negative histories are there. No? Whatever we told till now is positive history. So what about the negative histories?
Before admitting the hospital, patient had any fever, cough, breathlessness?
Yeah, but they are very clearly they are telling after 3 days patient started having this. So duration of fever, we know it is post-admission. Negative histories.
Surgical intervention.
This is a trauma patient. The patient had a shaft of femur fracture. What have they done for the shaft of femur? That has to be told here, no? Whether they have done internal fixation or what they have done is
They
very
put
important.
an external traction for this patient. There is no any surgical intervention done for this patient.
External traction of by skin or
By skin,
bone.
by skin.
By skin. That is important because what is one of the differential diagnosis? It's a hospital acute infection. This is after 48 hours. It can very well be a hospital acute infection. Then the question is, what is the source? So if the hospital has done a procedure, that surgical procedure can be a source of infection here. So providing skin traction is a non-invasive modality. If they are given a bone traction, that bone traction, if not done in a septic way, can cause new infections, right? That's why what has been done for the shaft of femur is very important. Internal fixation, also surgical this thing. Even if it is not surgical area, the patient might be on Foley's catheterization, isn't it? So if Foley's is not inserted properly or didn't use aseptic mechanism, patient may be having UTI. So what has been done to the patient for last 3 days in the hospital is very important here. Okay, what else? What are the other negative histories you will ask? What other adjoint histories you will ask?
Any chest trauma.
Yeah, chest trauma. Why chest trauma is important? What type of, how can chest trauma present after 3 days?
Any pulmonary contusions.
Yes, so patient may not have a rib fracture. Absence of rib fracture will make the patient less, difficult about the chest pain. When he is having a shaft of femur fracture, pain will be more towards shaft of femur and patient will be distracted from a chest wall injury. But if there is a fracture, definitely, if rib fracture is there, patient will have difficulty in breathing. Each time patient will have pain on breathing, so patient will vocalize that he is having a difficulty there. But if there is no fracture, patient might be okay with the pain here because there is something more painful over the leg. But a chest injury can cause lung contusion without fracture. And a lung contusion can get infected in 48 to 72 hours. So that may be the reason patient is having crepitations, desaturation and fever. So a chest wall injury is very important here. Chest wall injury can also cause what? Atelectasis, lung volume collapse, atelectasis, collection of secretions, pus and infections. So that history is important, chest wall history. Then what else?
Fat embolism.
In history, how can we ask fat embolism? Can we ask the patient fat embolism is there?
History-wise, we can negative altered sensorium.
So why altered sensorium is important here?
After 3 days history, then patient acutely developing altered sensorium. There is free fatty acids.
That is because we are biased towards today's topic. This patient having altered sensorium with new onset fever, you should suspect meningitis. It's not fat embolism. So don't get biased towards the topic. Present the case. This patient, when he presented with in our department, we didn't suspect fat embolism. No? So present the case. What other native histories were there? What other native histories do you want to ask? A patient had a history of fall from bike, skid and fall. Bike fell on his foot. Do you think a shaft of femur fracture is an isolated injury patient will develop? Patient can develop other injuries. What other injuries? It can be aberrations. It can be lacerations, aberrations. Where is the patient falling? On the road. Patient can get cellulitis. This patient is having fever. So don't you want to say whether any other injuries are there in the body? Shaft of femur is the major fracture that we are seeing. What about other injuries? So that part in history, these are the negative things you need to ask the patient and present. This patient didn't have any other foci of infection. Right now you just know that this patient has fever. So fever's most common conditions And trauma-related conditions is what we have to rule out, isn't it? So trauma-related is chest wall injury causing pulmonary contusion, atelectasis, infection. More common is abrasions and lacerations which is not cleaned properly or sutured properly, getting infected, causing cellulitis, necrotizing fasciitis, isn't it? The patient was wearing a pant, no one thought about opening it and seeing there was abrasions there. Patient get infected, right? These histories should be taken. Okay, fine. So, what else? Examination part.
Head to foot examination, there is no external injuries over the head area. Pupils are bilaterally reactive. On right chest, there is no chest tenderness, on abdominal tenderness, pelvic tenderness, right side, right thigh tenderness is there. There is no pelvic tenderness and abrasion present on the right palm area and right forearm, and contusion over the right side.
See,
thigh.
These things are there. So when you are saying this on examination, history, these are the things that you have to say. It's not infected.
And right thigh, there is a contusion mark on the mid thigh. Another system-wise examination, patient was conscious and oriented. Respiratory system, there is crepitation bilaterally is there. Other system within normal limits.
Okay. So crepitations, good air entry, bilateral crepitations, basically in infraatrial areas with tachypnea, tachycardia and desaturation. Okay. In clinical examination, what other history are you missing? You didn't say two very important points. Rashes, true, rashes is important. But you told a history of a shaft of femur patient post injury, not surgically managed, managed with skin traction. Is the patient walking?
No.
So what is the first native history you have to say? Whether there is a unilateral lower limb edema, the first and foremost DD for this patient is DVT. It's not any other thing, it's a DVT. It's a unilateral immobilized leg. Patient is bedridden. 3 days, sharp 3 days, time for DVT development is done in acute conditions, isn't it? So first and foremost, clinical examination that you have to say in primary clinical examination is edema. Pala rectus edema, right? So unilateral limb edema is very important here. Once unilateral limb edema is done, then all your examination comes. Then examination of the site of injury is important because it's a closed femur. Closed. Otherwise, they would have already opened and properly done an internal fixation. But it's a closed femur fracture. Shaft of femur fracture, there are 2 major vessels traversing through that area. What if the patient is having a venous injury with an internal hematoma? So, injury site should be examined. Should be looked for localized rise in temperature, look for local tenderness other than any collections, indurations. It can be an injury to the muscle hematoma or venous hematoma that is causing the source of infection, right? Otherwise, a closed shaft of femur fracture is a sterile area, isn't it? This patient is having fever. So what is causing the fever we should look for, right? So if you're palpating and seeing that other than the deformity of shaft, there is a localized collection or on muscle tenderness is there. For muscle tenderness, you don't have to palpate deeply, right? So these things are important. So local examination and associated limb edema is 2 things that has to be mentioned here. Okay, now coming to differential diagnosis. What are the differential diagnoses? As we earlier told, it can be
hospital-acquired pneumonia.
Hospital-acquired infection. That is one of the commonest thing. Whether the patient was on Foley's or not is very important here because it can be a Foley's insertion, aseptic Foley's insertion causing UTI. So that history. It can very well be a DVT. Can DVT cause fever?
Yes.
All thrombo thrombosis in the body, if significant, will cause fever. That is a inflammatory fever, not infective. So since history we can't identify whether it's inflammatory fever or infective, patients with MI, patients with CVA, patients with DVT can present with fever. So DVT is second in line for us. What is the third? Any other trauma related infections. Okay, now coming to fourth or fifth differential diagnosis, what we have to keep in mind is fat embolism. So it's not like our primary diagnosis, it's down the line, but fat embolism we should consider in this condition. Now we'll come to the fat embolism discussion as such. Why we should consider fat embolism in this patient? Why we should keep that in mind? It's already 3 days over. Young patient. It's not an open injury.
Sure. Basically, history-wise, there is a shaft of femur fracture. It is more common fracture causing.
So, what are the common fractures that can cause fat embolism?
Pelvic trauma fracture, large bone fractures like femur, tibia, polytrauma fractures, reconstructive surgeries.
What reconstructive surgery?
Bone reconstructive.
Yeah. So basically, orthopedic surgeries, intramedullary nailing, bone resections. Basically, either surgeries, but that is not fracture, right? So fractures, we have pelvis and long bone fractures. These are the most common fractures that can cause. Then orthopedic procedures. Patients undergone orthopedic procedures. Arthroplasty, hip arthroplasty, pelvic arthroplasty, knee arthroplasty, any other bone resections being done, or intramedullary nailing being done. These are the common procedure related fat embolisms we should suspect. So these are basically trauma, right? Even if it is procedure, even if it is medically controlled procedures, it is still trauma to the bone. Can you develop fat embolism without trauma?
Yes.
What are the conditions?
Diabetes, hypertriglyceridemia, liposuction.
Diabetes and dyslipidemia is one of the most common diseases we have in our world, right? So for each patient presenting with that, if we say fat embolism, that will be our main job. What are the other things? Liposuction. So medical procedures, liposuction we should suspect. What else?
Pancreatitis.
Acute pancreatitis. So basically you should think about conditions that can precipitate fat release from the body. So acute pancreatitis releases fat, saponification, right? So acute pancreatitis can be there. Then
total parenteral nutrition given for patients like
total parenteral nutrition is there.
Decompression sickness.
Decompression sickness. Good. Decompression sickness. So that what we should think about. What else? Any other surgical patient, post-surgery? Lipid-based injection, liposomal injections. Good topic. So, where do you give liposomal injections?
Amphotericin B.
Oh, no. That liposomal amphotericin B. No. Where will you give? IV?
Local lignocaine.
Yes, lignocaine toxicity. Yes. So that is in toxicity. Good. That's a good thing. Like IV liposomal injectables that we give in toxicity, especially lignocaine and all. If we are injecting directly into the bloodstream, that can cause. Okay. What other post-surgery?
Pregnancy.
Pregnancy. True. But that is amniotic fluid as such. What other post-surgery other than the long bones and pelvis?
CA breast.
Sternotomy. Post-CABG valvuloplasty, sternotomy patients can develop fat embolism. Then sickle cell. Hemoglobinopathies, mainly sickle cell disease, can cause fat embolism, especially that sickle cell patient has previous episodes of avascular necrosis or organ ischemia due to sickle crisis. This patient can develop fat embolism. What other condition? Anything else? Severe burns. Yes, more than 50% of total body surface area. Severe burns, you can get fat embolism. Okay, so there are non-traumatic conditions of fat embolism also. So coming to etiology of that. But most common etiology of fat embolism is untreated long bone fracture. So it's untreated. The incidence of fat embolism is pretty low in the current scenario because most of the closed or open long bone fractures will be taken up for immediate internal fixations. So rarely only, not rarely, like less than 10% cases only we see in a day-to-day practice because patients do not have that injury continuing for like 72 hours nowadays. So etiology part is over. Now, how will patient present? What are the presentation features of patients?
Fat embolism. Sir, patient presented with clinically tachycardia, tachypnea, breathing difficulty.
Basically, patient will develop breathing difficulty. Along with that, patient will have tachypnea, and because of tachypnea, patient will also have tachycardia. What else?
Some patients develop petechial rashes and altered sensorium.
So, what are the organs that are most commonly involved in fat embolism?
Primarily affected by lungs, then it's affected CNS, skin, kidneys, liver,
Heart.
heart.
Fine. So, basically almost all organs in our body, right? Yeah. But my question is, where does this fat embolism occur? In veins, right? How does this fat embolism go to brain, heart,
In
liver and kidney?
Fat embolism occurring patients in 22% have that patent fossa ovalis, so that way patient entering to the left ventricle.
22% of patients having fat embolism has patent fossa ovalis, not 22% of population.
No, sir. No. Patient who
but
having fat embolism.
Most of the patients having fat embolism develop all these organ failures, no? Why?
Due to patent ovalis, entering to system circulation.
Now, the thing is, initial concept was anatomical concept. That means there should be some shunt between vein and artery in which the fat globules are crossing over and going. But the more case studies and all came, they clearly understood that even without AV fistula, AV malformation patients or patent fossa ovalis patients, they develop these things. So current concept is SIRs. Fat embolism, basically there is something known as fat embolism and fat embolism syndrome. So fat embolism basically means there are fat globules in your venous system. So you do the microscopy, you get fat globules, free floating fatty globules, you say that patient is having fat embolism. Doesn't mean patient will go into syndrome. When fat embolism progresses, it is called syndrome, and syndrome is called when patient develops systemic effects. When the systemic effects develop, it's mimics like SIRs. It can be due to SIRS, multi-organ dysfunction, or it can be due to there are other biochemical pathophysiology and all is being explained, but we don't have to go in deep with that because this is a clinical discussion. Basically, it says that presence of fat inside the blood vessels cause release of free fatty acids from the body. So it's not from the site alone, from all over the body, free fatty acids are released.
Cytokine related.
Yeah, so that be that, but it's not that it is distributed from venous side to arterial side. It's a whole body phenomenon. Okay, that's why this much of organs are getting affected. So one of the most common presentation in skin is petechial rashes, and along with petechial rashes, these patients can also have thrombocytopenia and anemia. So anemia, thrombocytopenia, petechial rashes and fever, we will say it is short febrile illness with fever, but it can be fat embolism, but don't say that unless the patient is having a open fracture or any other etiology that we earlier discussed. But Yeah, you will have fever with thrombocytopenia, anemia,
oliguria.
and petechia. Then, depending on the organ it is affected, you will have its own symptoms. If you are having renal involvement, you will have oliguria, anuria, renal shutdown. If it is in the lungs, you will have breathing difficulty, hypoxemia,
Pulmonary
and
edema.
progression will be, pulmonary edema, ARDS like progression. Okay. If it is a heart, you can have myocarditis with cardiac failure, cardiogenic shock. And if it is brain, you develop,
Altered sensorium, coma.
yeah, why?
Because the free fatty acids affect the brain tissue.
It causes local inflammation of brain tissue causing increase in edema. So basically, neurological features of fat embolism is not due to fat embolism, it's due to local edema caused by the inflammation. Okay, so what are the CNS manifestations? Altered behavior, confusion, agitation, coma, seizures. Okay, fine. So nearly all systems presentation we have just told. How to diagnose?
We can use Wilson's criteria to diagnose fat embolism.
So what is Gerd-Wilson's criteria?
The major criteria and
Minor
minor
criteria.
criteria.
Three major criteria are?
Three system, it is on lungs, respiratory distress,
Oh, one organ we missed. Eyes.
eyes. There is retinal involvement, fundoscopy examination, we can see arterial blocks there,
Retinopathy we can
petechial
see.
rashes.
Okay, so major criteria for Gerd-Wilson.
Three systems: CNS, altered sensor, agitation, confusion, coma, lungs affected by respiratory distress, ARDS, pulmonary edema, and skin petechial rashes.
Petechial
That
rashes.
is
So
Bernard's.
petechial rashes, lungs, CNS, three major criteria. And minor criteria?
Minor criteria: fever, tachycardia,
Heart rate more than
more than 100,
110.
110.
Anemia.
Anemia, thrombocytopenia, kidney involvement leads to anuria, oliguria, icterus, fat globules, microglobulinemia, we can identify in urine and sputum.
Yes, urinary sputum.
Retinal involvement. One major plus three minor criteria is there, we can.
So this is the criteria. How do you diagnose it? What are the ancillary tests you can do to diagnose this?
We can check the fat microglobulins in urine and sputum.
Yeah, that is the thing. You can check for free fatty globules in the blood, urine, sputum. It is widespread all over the body. So you can check any systemic secretions and you can see for fat globules. What else? X-rays. You take X-ray and look for pulmonary edema-like features, isn't it? This thing is actual description of fat embolism in lungs is, what is the description of fat embolism in lungs? Snowstorm appearance. Looks more like ARDS, pulmonary edema, but it's called snowstorm appearance. Okay. What else? You can take a CT. CTPA to rule out basically pulmonary embolism. That's basically to rule out pulmonary embolism. But CT thorax, you can see infiltrations into the pulmonary vasculature of fat globules. Okay. So, investigations we told. Now coming to management. How do you manage this case? What is the definitive management of fat embolism? Is there any definitive management? Is there any drug or procedure you can do to reverse this? There is no definitive management for fat embolism. Treatment is purely supportive. So whatever symptoms the patient develop, we support the patient and try to resuscitate that organ. So patient is having respiratory symptoms, patient is having severe hypoxia, start the patient on oxygen. If patient's oxygenation is worsening and developing features of ARDS, ventilate the patient. Ideally in mild ARDS like situation, start with NIV. If moderate to severe, go for tracheal intubation and mechanical ventilation. If patient is having oliguria, go for renal replacement therapy. Patient is developing cardiac failure, cardiogenic shock, start the patient on
IV fluids and ino drops you can use.
Already your heart is failing. Inotropes you should give, not fluids. It's not RV, it is LV. So inotropes. What inotrope will you give?
Noradrenaline, dopamine.
Dopamine, but already heart rate will be quite high. So dopamine will not be a safe choice here. So dobutamine. Okay. Then what? Patient is having altered behavior, confusion, agitation, seizures. How will you manage? Anti-edema measures, we just don't know. So intracranial, it is due to rise in ICP causing these features. So anti-edema measures, what will you give? 3% saline, mannitol. Mannitol only in extreme condition like seizures and all only you should give. Initial altered behavior, confusion and all, you just start the patient on 3% saline and
Heparin also given this patient.
Anti-edema measures. Anti-edema, 3% saline and anti-seizure medications. Propped up position, anti-seizure medication, eptoin or levetiracetam, whichever your institution is preferring, that you can start. And in seizure conditions, you can start the patient on mannitol. Fine. So that is brain, lungs, heart, kidney. Yeah. So then heparin. Will you give heparin in fat embolism?
Heparin has both activities. It will prophylactically we can give, and also it has a lipase dissolution activity also.
Have heparin been recommended by any guideline? No. With any of the studies, heparin was not found to have any improvement in mortality or morbidity of the patient. But as you told, heparin is given prophylactically. Why?
Immobilization also causes.
Basically, there is a DVT risk. So you give heparin prophylaxis to prevent DVT.
And lipid dissolution action also is there for heparin, so we can give.
The difference in those things are there will be lot of pharmacological actions for a drug. Doesn't mean that actions will be seen clinically. That's why we do clinical studies in which we check whether that drug does what it is supposed to. The test clinical trials haven't shown heparin making the mortality decrease or morbidity decrease for these patients. But then when you give heparin for a already established fat embolism patients is what we are saying. For this patient, you diagnose this to have fat embolism, you start heparin, it doesn't make sense because heparin is not going to prevent further fat embolism. Already happened, it's not going to treat. Only thing it is going to do is make the patient anticoagulated, increasing his bleeding risk when there is already a closed fracture inside. But if this patient came with trauma, you make sure there is no vascular injury and you are like, unfortunately, we can't do surgery in a immediate setup. We have to wait for some reason. You can start the patient on heparin prophylaxis. That's mainly for DVT rather than for fat embolism. But pharmacologically, yes, heparin has fat dissolution features. But what other drug which we commonly use in ER has actual anti-fatty acid action? Statins, true, but not statins. We don't usually use statins, so we use in MI only. What else? Steroids. So you start the patient on steroids. First of all, what we have to understand is, I'm not that well versed in this, but steroids has anti-inflammatory activity. And inflammatory response is what you see in fat embolism. So you giving steroids will suppress the inflammatory responses, especially cerebral complications of the patient. Fat embolism as such, whether steroid will improve or not, we have to check the studies. I'm not sure whether it will check. But definitely patients' symptomatology, it will improve a lot.
Ideally, fat embolism causing altered sensorium, we first give steroids.
So, anti-inflammatory action. Yes. Other than that, it's all supportive management. IV fluids if patient is hypovolemic, intubation in case of airway derangement or hypoxemia, renal replacement therapy, and give time for the patient to resolute. Usually in 5 to 7 days, the fat embolism syndrome subsides down. Basically, the inflammation due to fat embolism syndrome subsides down and patients come out of it. Mortality is less than 10%. But till then, we have to support the patients with symptoms. Anything else?
The other DD we can, in this patient had a history of 3-day immobilization, so other DD is pulmonary embolism due to
DVT, pulmonary embolism is the thing. We didn't go into that because then we have to discuss about DVT and it will be a huge class. So we want to discuss fat embolism today. We'll stick to it. DVT already we have discussed once earlier. No? So primary diagnosis, as we told, this is first and foremost thing is hospital acquired infection. LRTA is the first DD you should make sure it's not there. Second DD is going to be DVT. So definitely DVT evaluation is there. We told first DD, second DD, third DD we told other infective pathologies in the body. Then fourth or fifth only fat will come. Since we want to discuss fat embolism, we did it today. Anything else?
Thanks.